Hey everyone, and a huge welcome to all the chemotherapy-trained pharmacists tuning in to this explainer. I am absolutely thrilled to have you here. Today, we're setting the stage for a high-yield, case-based review of acute lymphoblastic leukemia, or ALL. We know that as oncology pharmacists, you are right on the front lines of managing complex chemotherapy regimens, navigating these intricate clinical guidelines, and mitigating severe toxicities. ALL is one of those rapidly evolving landscapes where the standard of care is constantly shifting thanks to incredible new trial data and targeted therapies. So grab your notebooks because we're going to break down some major clinical pearls that you can take straight back to the infusion center.
Okay, let's dive right in. Here's our roadmap. We'll be conquering 5 critical decision-making nodes today. First, the adult ALL landscape. Second, tackling Phe-positive ALL. Third, navigating Phe-negative protocols. Fourth, the MRD-negative game changer. And finally, managing a high-stakes tumor lysis syndrome scenario.
So let's kick things off with Section 1, the adult ALL landscape and establishing our baseline.
Look, before we even think about treatment protocols or targeted agents, we have to remember that precise subtyping is the absolute foundation of ALL treatment. I mean, you can't build a house without a blueprint, right? And you definitely can't treat ALL without knowing exactly what kind of rogue cells you're dealing with. So, adult ALL is typically subtyped into 2 core groups, precursor B-cell ALL and mature B-cell ALL. Establishing this right out of the gate is, well, it's non-negotiable. It literally dictates our entire treatment algorithm. The specific biology of these subtypes drives how aggressive we need to be and which specific agents are going to hit the hardest. Once we've got our lineage and maturity locked in, we immediately start looking for our most important genetic marker.
And that brings us to Section 2, tackling Phe-positive ALL and the TKI integration.
This right here is our first major branching point. The presence or absence of the Philadelphia chromosome completely alters the trajectory of our patient's care plan. If a patient is Ph positive, combination strategies are the absolute standard of care. So here's your first major clinical pearl. Clinical trials have essentially cemented the integration of tyrosine kinase inhibitors, TKIs, into the frontline setting. We typically use an intensive chemotherapy backbone, something like hyper-CVAD, but the real magic happens when we integrate that TKI. While first-generation imatinib totally paved the way, nowadays we heavily rely on second-generation TKIs. We're talking dasatinib or nilotinib, combined with that multi-agent chemo. This combination approach has just dramatically deepened remission rates and improved long-term outcomes for our Ph-positive patients. It's a real game changer.
Moving right along to Section 3, navigating Phe-negative protocols and choosing the right backbone.
But what happens when the Philadelphia chromosome is absent? How do we pivot our strategy? Well, let's put this into practice with a rapid-fire clinical case. Meet DH. He's a 55-year-old guy presenting with a severely elevated white blood cell count. We're talking 80.4. His bone marrow confirms he has Phe-negative B-cell ALL. Now, think about your NCCN guidelines for a second. Which protocol is the preferred choice for a patient like DH? Go ahead and lock your answer in your head right now.
Okay, let's see what you were thinking. Here are the primary NCCN protocol considerations you're likely weighing for P-negative ALL. We've got CALGB 1043, CALGB 9511, which you probably know as the Larson protocol, hyper-CVAD, and the ECOG Akron E19010 regimen. Now, while hyper-CVAD and the Larson protocol are incredibly common standard choices for adults, there is one massive distinguishing factor that dictates our regimen selection here, and that factor is age.
Now, what's really interesting about this slide is how age completely stratifies our approach. A massive clinical pearl in ALL management is that older adolescents and young adults, the AAY population, actually derive a significant survival benefit from pediatric-inspired regimens, like CALGB 10403. However, let's look back at our patient, DH. He's 55 years old, so he falls firmly into the older adult category. Because of his age, he's a lot less likely to tolerate the intense asparaginase doses that you'd find in those pediatric regimens. Therefore, for DH, standard adult protocols like hyper-CVAD or the Larson CALGB 9511 protocol are the preferred pathways. Matching the intensity of the regimen to the patient's biological age is an absolutely crucial pharmacist intervention.
All right, let's shift our focus to Section 4, the MRD-negative game changer and its survival benefits. We're about to look at some seriously groundbreaking trial data that is actively shifting our consolidation strategies right now. But before we do, let's just make sure we're all on the exact same page regarding measurable residual disease.
MRD-negative remission is defined as the complete absence of detectable leukemia cells in the bone marrow or blood, using highly sensitive testing methods like flow cytometry or PCR after that initial treatment. Achieving MRD negativity is basically the holy grail of ALL induction therapy. It's the single strongest prognostic indicator for long-term survival. But the lingering question has always been, okay, what do we do next once they actually achieve it? Well, this brings us to another massive clinical pearl, this one straight from the ECOG Akron E1910 trial. Historically, we reserve targeted immunotherapies like blinatumomab, the CD19/CD3 bispecific T-cell engager, for patients who had MRD-positive disease or a frank relapse. But E1910 totally flipped the script. This trial demonstrated that adding blinatumomab as consolidation therapy actually improves overall survival, even in newly diagnosed adult patients who are already in MRD-negative remission. Let that sink in for a second. Blinatumomab isn't just a rescue agent for MRD-positive disease anymore. It's rapidly becoming a frontline consolidation standard to deepen remissions and cure more patients, even when we literally can't detect the disease anymore.
Finally, let's move to Section 5, Managing Tumor Lysis Syndrome, a high-stakes clinical scenario.
As pharmacists, we all know that administering the right chemotherapy is really only half the battle. Effective leukemia management requires incredibly aggressive complication prevention and supportive care. So let's check back in with a slight variation of our patient DH. Let's say he has Phe-positive ALL, and he's currently on day 2 of his induction with hyper-CVAD and dasatinib. You pull his morning labs and, well, they're alarming. His white count is 42, his BUN is 36, his serum creatinine has jumped to 2.2, potassium is 5.7, phosphate is 4.9, and his LDH is a staggering 2810. He is actively tumor lysing right now. He's already receiving allopurinol, but based on this clinical picture, what is the absolutely most appropriate next step in his TLS management?
And to make matters worse, you see his uric acid level. It's 8.6 milligrams per deciliter. This is an absolute immediate crisis. His kidneys are taking a massive hit, and the allopurinol alone is just not going to clear the existing uric acid burden fast enough to save his renal function.
So the crucial point here is understanding exactly how to escalate. Step 1 is always aggressive hydration with normal saline to flush those kidneys. Step 2 is baseline allopurinol to stop the formation of new uric acid. But step 3 is the critical intervention for DH. We absolutely must escalate to rasburicase. Remember, allopurinol only prevents new uric acid from forming. It does absolutely nothing to clear that 8.6 level that is currently destroying his kidneys. Rasburicase, on the other hand, is an exogenous enzyme that rapidly degrades the existing uric acid into allantoin, which is a highly soluble compound that the kidneys can easily excrete. Given his elevated creatinine and hyperuricemia, rasburicase is the correct and honestly the necessary answer to rapidly reverse this life-threatening complication.
As we wrap up this explainer, I really want to leave you with a provocative thought. We've seen how integrating TKIs and leveraging blinatumomab based on MRD status have vastly improved survival. But as our ability to perform next-generation genomic testing becomes faster and even more precise, how is that going to further redefine our definition of standard of care in ALL? Are we eventually going to have a highly specific, non-chemotherapy targeted agent for every single genomic permutation? It's a fascinating frontier. And as chemotherapy-trained pharmacists, you are going to be the ones guiding these precise therapies in the clinic. Thank you so much for joining me for this explainer. Keep optimizing those regimens, and I'll catch you next time.